Welcome to our session, Today or Not Today. It is my great privilege to welcome two distinguished leaders in the fields of endocrinology and nephrology, whose work continues to shape the clinical practice and improve patient care across the country. Dr. Anastasios Pittas is a professor of medicine at the Tufts University School of Medicine and the chief of the Division of Endocrinology at the Tufts Medical Center. He's internationally recognized for his groundbreaking research on the role of vitamin D and type 2 diabetes in cardiometabolic disease, supported by NIH and the American Diabetes Association. He also was the principal investigator and the chair of the vitamin D type 2 diabetes prevention trial, a landmark multi-center study. And in recognition for his high-impact, ethical, and rigorous work, he was honored with the Biomedical Research Exemplar Award. Most recently, he has served as the co-chair for the Endocrine Society Clinical Practice Guidelines on Vitamin D for Disease Prevention, a role that reflects both his expertise and his commitment to evidence-based care. Joining him is Dr. Wiener, we all know about him, full professor of medicine at the Tufts School of Medicine and a practicing nephrologist at Tufts Medical Center, where he directs the dialysis program. He also serves as the medical director of DCI Boston and as the national medical director of clinical research for DCI, a leading nonprofit kidney provider. Dr. Wiener is editor-in-chief of Kidney Medicine, the open access journal for National Kidney Foundation, and he also serves on the ASN Council. His research focuses on dialysis care and the complex interplay between cardiovascular and kidney disease, making him a vital voice in advancing kidney health at both local and national levels. Please join me in welcoming Dr. Pittas and Dr. Shah.
Thank you so much for this wonderful introduction. It's always amazing to find out things about yourself. Okay, so this is my disclosure. Some people think that being an endocrinologist should be a disclosure. Okay, learning objectives. So I'm going to go over the Endocrine Society Clinical Practice Guideline on vitamin D for disease prevention, because a lot of the vitamin D care that you provide can be similar to people without kidney disease. All right, so I'd like to start with a case, and there's going to be a Slido. So get ready, but pay attention to the case. So John is a 56-year-old black man with a hemoglobin A1C of 6.2 and a fasting glucose of 118. 2 years ago, A1C was 5.9 and fasting glucose was 110. He has CKD G3A. Over the last 2 years, he started the Mediterranean diet, has increased his exercise duration to at least 150 minutes weekly, and he takes a multivitamin that has 600 units of vitamin D, which is what the RDA is for his age. His BMI is 26 and has remained unchanged. So, a little overweight, he's doing the best he can, but his prediabetes is slowly progressing. So what would you do next? Would you encourage him to do even more caloric restriction and physical activity? Do you recommend vitamin D in addition to the RDA? Do you start an incretin receptor agonist like semaglutide? Or do you measure the level and just see what happens? Okay, I think we have 43. That's nice, okay. All right, so most of you say we will measure vitamin D and then, decide what to do next. Okay, that may not be the correct answer. So in preparation for this presentation, I went to the KDIGO 2024 clinical practice guideline. I searched for vitamin D, and I saw one sentence that said, please see 2017 guideline. So I went to the 2017 guideline, and it was a long document. I think I read it many years ago, but there are two recommendations there relevant to this. The first one is in patients with CKD 3 to 5, we suggest that 25-hydroxy-D levels might be measured, and repeated testing determined by baseline values and therapeutic interventions. I guess you're all following the recommendations, so you're testing, but I'm not sure if this is a very specific or very useful recommendation. The second recommendation is that we suggest that vitamin D deficiency and insufficiency be corrected using treatment strategies recommended for the general population. That again sounds reasonable, but it does not define what deficiency or insufficiency is. Now, I'm sure you've said this to your patients. You are deficient in vitamin D. And it's important to take vitamin D. This is a simple sentence, but let's dissect it. Deficient, what do you mean by deficient? Your patient will ask you. Now, vitamins are substances that must be ingested in tiny amounts in the diet because our body cannot make it. So vitamin D, in that sense, is a vitamin because it is found in foods, but not in foods that we typically consume on a daily basis. So most of the intake comes from supplements, either pills or food like milk, dairy products, cereal that is supplemented with vitamin D. The reason why vitamin D does not really exist in foods we eat, is because the evolutionary appropriate method of obtaining vitamin D is through cutaneous biosynthesis. Of course, that's not what we're doing. Today might be a good day for you to be indoors, but typically you should not be indoors doing what we're doing most of the time. And so most of us are indoors in front of a computer, and the dermatologists have done a fantastic job to shield all of us from sun exposure. So therefore we have changed a little bit the evolutionary appropriate way of getting vitamin D. Okay, deficiency. What is deficiency? Deficiency in relation to vitamins is a specific condition. So if you have no vitamin C, you get scurvy. If you have no vitamin D, you get rickets or osteomalacia. That is deficiency. Deficiency is not a level below your favorite threshold, okay? Now, as the discussion has evolved over the last decade or two, we now talk about, suboptimal levels, perhaps. So is vitamin D useful to prevent some disease state of some sort? And then some people also talk about optimizing vitamin D level for just maximize physiologic functions and optimize well-being, and in general confer minimal or lesser risk of disease. So I would be very careful to use the term deficiency unless you mean it. Deficiency is defined by a disease state in relation to vitamins, not on the basis of level. Okay, then the patient will say, what do you mean in vitamin D? Okay, as you know, vitamin D, whether endogenously synthesized or exogenously ingested, it binds to vitamin D binding globulin, goes to the liver where it is hydroxylated to 25-hydroxy-D, and this is, of course, the level we measure in clinical practice as a biomarker of vitamin D status. Most of it is D3, which is what we make or what we can buy in the, at the pharmacy, but many of you may give ergocalciferol, which is the D2, so when you measure the level, that captures both D3 and D2. Okay. When we think of a biomarker of vitamin D status, there are at least two ways to think about this. One is as a biomarker of exposure. So that is a validated measure to reflect intake or biosynthesis. Blood 25-hydroxy-D level is perfect for that. So in this study, the investigators gave a huge dose of vitamin D, 500,000 units, IM, once a year. And as you can see here, or I don't know if you can see here the levels. Okay, the levels went up very nicely after each dose and remained higher than the placebo throughout the study. So if the only thing you care about, and I know many of you do care about this, is to raise 25-hydroxy-D level, this is the way to do it. Don't do it. Okay, why not? Because, I mean, this is beautiful, right? Why not? Because in this particular study, the investigators had the hypothesis that raising the vitamin D level will lower fractures, will lower falls, and good things will happen to you with just one injection a year. Well, the exact opposite happened. So people who received the vitamin D or were randomized to vitamin D, they actually had more falls and more fractures throughout the study. So this is not a good approach, even though the 25-hydroxy level went up and stayed up throughout the year. Another way to think of 25-hydroxy-D is as a biomarker of effect. And by that I mean a causal association with something that you care about, an important health outcome. A biomarker of exposure is not the same as a biomarker of effect necessarily. And we always like to have some kind of effect when we think of in clinical medicine. Now, I know a lot of you, me included, we measure PTH, we like PTH, and we like it to be low. And so this is, if you take a lot of people and you measure their vitamin D level, the lower the vitamin D level, the higher the PTH will be. Or another way to think about this is if I supplement people with vitamin D, then the PTH will go down, and at some point it will plateau, and that's awesome. And we know that PTH is, it's bad for you, and so by lowering PTH, that's a good thing. Okay, that's nice. It turns out life is much more complicated than that, because this is what the curve looks like in different ages. So for the same level of vitamin D, the PTH may be very different. This is just age, so probably that reflects maybe some underlying CKD or something, right? So then the question is, what should the target PTH be? It turns out that life is even more complicated, because if you take 1,000 people, this is what it looks like. So yeah, the correlation is beautiful, but when you add the nuance through the individual measurements, it gets messy. So I don't really know what a normal PTH for me or for you should be. Assuming you don't have kidney disease, then it gets complicated, but that's what Dan will talk about. All right, so I'm going back to this, and I'm going to bold and underline important health outcomes. So the way we want to think about vitamin D and 25-hydroxy-D is like LDL. Okay, a high LDL is bad. I do something about it. I lower the LDL. Good things happen. Okay. A high HDL is good. Sorry, a low HDL is good. I do something to raise HDL, nothing happens.
No. Low HDL's bad.
Got that much. Yeah, well, okay, you know what I mean. So just because, thank you. Just because, right, Dan. So just because something is cool, is associated with something doesn't mean that doing something about it will result in, good things. So when we think of a biomarker in terms of effect, we need to think in relation to an outcome. I use diabetes because that's my favorite outcome, and because obviously it's very common, you see that. And there are several prerequisites that need to be met for a biomarker like vitamin D to be linked to an outcome like diabetes. So these are the all the different these are called the Bradford-Hill's criteria or guidelines. And in relation to vitamin D, there's no question that vitamin D and diabetes, plausible mechanisms exist, temporal relationship, strength of the association, dose response, all of these. There's tremendous consistent evidence from observational study, longitudinal observational studies showing that if your vitamin D level is high, you are at lower risk of developing diabetes in the future. That's not even controversial, okay? But just because something is strongly associated doesn't mean that, it is causally related. And we have to think about alternative explanations for that association. So this slide shows factors that contribute to low 25-hydroxy-D level. So vitamin D level, biosynthesis, intake. So if you dark skin pigmentation, if you don't get out too much, or if you live in Boston, or if you're aging, which is always a risk factor if you're alive. If your intake is low, that all contributes to low vitamin D status. And then there's a lot of other factors that may interfere with the hydroxylation. When you think of intake, most of us don't ingest vitamin D in pills. Maybe we do, maybe we don't. But we also eat a lot of other things, dairy, dietary healthy patterns. So when you try to tease out the association between vitamin D and your outcome of interest, it gets a little messy. This slide shows that a lot of the factors that contribute to low vitamin D also contribute to the risk of type 2 diabetes. And you can replace this with other outcomes of interest to you. So the question then, or the point is, that confounding is a major or a potential major pitfall of observational studies. And one may question, is vitamin D status simply a marker of health and diabetes risk? And a strong association doesn't necessarily mean that supplementation would be beneficial. So therefore, experimental evidence from trials is needed to answer this question and to answer the questions that your patient has. Why is it important? How much do they take? How often? And then you're like, I don't know. Okay, so these are the Endocrine Society guidelines that came out last year that this is a busy slide. You're going to have access to the slides so you can enjoy them at your leisure. But there's 3 categories here. One is that if you are between 19 and 74, of course, there's nothing magic about these ages, but if you're between these ages and you're healthy, just take your vitamin D according to the IOM, and you don't need to worry about taking too much more. There's certain categories: children, older people, pregnant people, and people with, actually adults, because there's no evidence in kids, adults with prediabetes, where taking vitamin D in addition to the RDA for your age would lower risk of disease. And the last kind of, controversial for some people recommendation is that we suggested against routine testing with 25-hydroxy-D, exclusively because we don't know what to do with it. But maybe you can tell me what you're doing with that during the discussion. Okay, I'm going to concentrate on those 2 parts of the guideline. Okay, to be trustworthy, guidelines should really have a good panel, a good process, and good data. I think most guidelines have a good panel. I can't question the panel. Most guidelines are good at looking at data. Okay, but not all guidelines have a good process. The Endocrine Society guideline now follows a very, very specific process, the GRADE methodology, and we actually followed the methodology to the T, not just like and that is a good thing in some ways because as I like to say, commitments create freedom. So there's less, subjectivity from the panel members to contribute their own opinions. Just as a quick slide to highlight that this was a panel and recognize the work of my colleagues. Okay, so we followed the GRADE process. This is a busy slide. I'm going to go through each one of them just to give you an idea of how we and how you should be thinking about these issues. Okay, first we formulated questions. Okay, so the KDIGO guideline, the ADA guidelines, they give you some not very specific guidelines that make sense. They're not. No one questions them, but they're not very helpful. So what we did was we questioned. We formulated clinical questions. So what are some questions about vitamin D that you have? What's the story with vitamin D? Right? Have you heard that before? What should I do about vitamin D? Should I take vitamin D? Okay, these sound like reasonable questions, but what's the problem with these questions? They don't have an answer. Might as well ask, what's the story with cancer? What should I do about chemotherapy? Should I take insulin? I don't know. Tell me more about it. So last year I asked ChatGPT, can you please give me 10 good questions doctors and patients have about vitamin D? This is what ChatGPT came up with. When I talk to ChatGPT, I know you do sometimes, I always say please, because when the computers take over, they will remember that I was kind to them. Okay, the panel addressed 3 kinds of clinical questions. First, we said, everybody needs vitamin D. Just go by the RDA based on your age. Great. So the question is, are there any populations that need more for specific conditions? Should we measure 25-hydroxy-D? In other words, does that make a difference? And are there certain subgroups, obese individuals, dark-skinned individuals that may benefit more? So we came up with 14 questions and recommendations, and we followed the PICO model, which stands for Patient Intervention Comparator Outcome. So for every recommendation, we had a question. In patients with condition, should intervention A versus comparator be used to improve outcomes? Now, that is a specific question that can be answered. Okay, what should I do with vitamin D cannot be answered. So in adults with prediabetes, we asked the following question. Should empiric vitamin D supplementation versus no empiric vitamin D supplementation be used in adults with prediabetes? By empiric, we mean without any testing. So there's your population, there's your I, your intervention, and there's your comparator. And when we try to answer these questions, we look at desirable effects, undesirable effects. And for this particular question, we had these outcomes. Of course, the primary outcome was new onset diabetes, but if we're going through the effort, we might as well just try to answer other questions in relation to this population. And also we look at the side effects. I forgot to mention, because one of your questions would be, well, how did you come up with this question? Well, we voted. So each member had, a question or 2 or 3. We had about 25 to 30 questions. We could not answer all of them. So then we voted, the top 10. The Endocrine Society said, okay, you can have 4 more for the same price. So we added 4 more. Okay, so we formulated the question, and then we sent the question to the Evidence Practice Center, and we said, hey, do meta-analysis to answer each of these questions and each of these outcomes. And each outcome had its own systematic review and meta-analysis. So, very specific, very methodological. Okay, so they did that. They came back to us with the evidence, and then we looked at the evidence. In adults with prediabetes, outside of the diabetes outcome, there was not a lot of evidence. So vitamin D in this population doesn't really do much to lower the risk of respiratory infections or fractures or all-cause mortality or cardiovascular events. Okay? In all the trials we looked at, there were no adverse events. So again, safety-wise, there's comfort. In relation to the primary kind of outcome or the main outcome for this question, the systematic review, the commissioned systematic review and meta-analysis was this. So the Evidence Practice Center found 10 trials, vitamin D and diabetes prevention trials. There are really kind of 2 major ones or 3 and a few small ones, but they all reported on the outcome of diabetes in adults with prediabetes, vitamin D versus placebo. And when you do the the synthesis of the evidence, vitamin D reduces the risk of diabetes by 10% in this meta-analysis. There are two other systematic reviews with aggregate data that give you have reported an identical result. In addition to the aggregate data, you can also do individual participant data meta-analysis. Of course, that's a lot of work for a panel to do, but our team got together with the other two major trials worldwide, and we did an individual participant data meta-analysis. And what we found there was that in adults with prediabetes, vitamin D reduces the risk of progression to diabetes anywhere from 13 to 17%, depending on the analysis we did. Intention to treat, adjusted, unadjusted, or secondary analysis. Most or all diabetes prevention trials have looked at progression from prediabetes to diabetes. Another outcome of interest that many large trials have reported is regression to normal glucose regulation. Okay, that's a good thing because you're staying away from anything that has to do with hyperglycemia. And in the participant data meta-analysis, we also found that vitamin D increases the likelihood of regression to normal glucose regulation by 30%. So not only do you lower the risk of people progressing, but you actually increase the likelihood of people regressing to normal glucose regulation. So the panel looked at that data, and in addition to that data, we also looked at other factors we call contextual factors. So is this an intervention that requires resources? What's the cost? Are there any equity issues? Is it acceptable? Is it feasible? Things like that. And of course, for vitamin D, all these questions are yes, 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 or no, no, no. So when we balanced the evidence and the contextual factors, we concluded that in adults with high-risk prediabetes, in addition to lifestyle modification, we suggest empiric vitamin D supplementation to reduce the risk of progression to diabetes. Of course, the natural next question is, okay, and how much vitamin D? As you can imagine, the trials use different doses. So what we did was we calculated we estimated the weighted average daily dose from all the trials, and that was 3,500. Of course, that dose doesn't exist. But you can give 4,000, you can give 5,000, but that gives you a guidance in terms of how much to give if you elect to give vitamin D to lower the risk of diabetes. Okay, just a few more slides here, because this is also something that is in your mind. We also wanted to answer the question, should we screen with 25-hydroxy-D in healthy adults, those with dark complexion, those with obesity? Because the idea is that if someone has low level, they may get more benefit than someone who has a higher level, and therefore it may make sense to screen, find those with low levels, and replete. No studies compared a screening strategy, and so what we did was we looked at all the trials and the subgroups, obesity versus non-obesity, dark skin versus no dark skin. The proxy, of course, here is, I'm starting a new presentation. Oh, am my time's up? No. All right, I think we're good. How do I go here, maybe here?
Just go rapidly forward.
Or just rapidly go forward. So we looked at the trials, and we looked at the subgroup analysis to try to answer this question. And we found no evidence that vitamin D works better in people who are obese or non-obese, people who have dark skin or not dark skin. And of course, the proxy for that was race, because people didn't report, or the studies didn't answer that question based on skin. Now, something interesting about people with who needs slides?
You didn't say please. You didn't say please.
Oh,
ChatGPT,
can you
please
please
bring back
go
my
slow?
slides.
Thank you. So something that comes up, in a discussion, and we can discuss it later, is people who are overweight. Their level of vitamin D tends to be low, and there are many factors for this. One is decreased bioavailability. Another one is that they may be reduced hydroxylation in the liver, and of course, their lifestyle may not be suboptimal. So you would think that people who are obese, who have obesity, they may benefit more. Well, I have news for you. It turns out that people who are not obese are the ones who benefit more in the trials, or at least there's a suggestion that they benefit more. And that comes from the D2D study, from VITAL study in terms of cancer and fractures. There's another study here in terms of respiratory infections. So if you look at the subgroup analysis, you see that people who are not obese are actually benefit more, or there's a trend to benefit more. So the recommendation we made was that in healthy adults, those with dark skin complexion and those with obesity, we suggest against screening. That's a low-level suggestion, so you don't have to follow it. But do not screen does not mean that thresholds do not exist. What we said is that we do not know what thresholds are appropriate, and in the absence of evidence, we elected to suggest against. And one last thing is that the terms normal, deficiency, sufficiency are nowhere, anywhere in the guideline. And these terms are used in the literature, but have no agreed upon definitions. They're relying almost exclusively on observational study. And these terms, I think that might be my most important point, is that these terms can only be defined for a specific population and a condition, and are likely to vary among populations and conditions. That's it.
That's it.
Okay.
Let's see if I can get this going. ChatGPT, please open up. All right. I am good. Thank you. So I think we're going to move now more into the world of CKD. And try to apply a lot of what Tasso was just saying to many of the patients that we see who have kidney disease. So just out of curiosity, after that talk, or even before the talk, how many of you routinely check vitamin D levels in your non-dialysis CKD patients? Okay, so most people. How many routinely check 25 vitamin D levels in your dialysis patients? A lot. Is this something the dialysis team does by protocol? Is this something you're electing to do? So dialysis unit protocols. All right. So we'll talk a little bit about this. I'll give away the end of the talk before we even start. We have no idea. All right, so everybody can go. It's lovely outside. Actually, it's really disgusting outside, so you're not going to get any vitamin D today, so it doesn't matter. So these are my disclosures. Actually, that doesn't work. So to move on, just as a quick summary, and I think most people know this, but going through what the effects are of vitamin D, I think one of the key things here is that this is 125 vitamin D. So this is the hydroxylated version, and we'll talk about that on the next slide. But vitamin D has a lot of effects across the body, including in organs we care about. So in the kidney, when you have kidney function, you're increasing calcium reabsorption, and that's important. What we focus on a lot in people with advanced kidney disease is bone, and vitamin D promotes bone formation and growth. It keeps the bone alive. It basically just promotes dynamism across bone. For parathyroid gland, vitamin D reduces PTH production. There are receptors, and it directly downregulates to 125 vitamin D PTH production, and it keeps the parathyroid gland from getting severe hyperplasia and from losing control into secondary to going to tertiary hyperparathyroidism. And then in the gut, and we know this very well from our dialysis populations, vitamin D increases calcium and phosphorus absorption, so it raises the levels of both of these cation and anion, both of these things, I guess, would be the term. So if you see on this, and this is one of the major questions that we have, is all of this in here is 25 vitamin D. This is the activated version, 125 vitamin D. And you'll hear some people refer to 25D as nutritional D because you get it from diet, or this is what you're making from through the skin from sun. 125 vitamin D is what happens when 25D for the most part, goes to the kidney and it gets an additional hydroxyl group. And this 125 vitamin D is the portion that is most active across the body, far more active than 25D is. That stated, and Tasso can correct me if wrong, there's also local conversion in certain tissues within the body of 25 to 125 vitamin D. So there's a lot of debate here. We know that this is really what's doing most of the work, at least in circulation, but there may be some areas where 25D locally is converted to 125D, which is its more active portion, to again have all of these effects that we discussed on the last slide. So quick case presentation or case question. We'll go through maybe 3 or 4 cases through this. And here it is. So 65-year-old woman, CKD stage G3B A2, GFR is in the low 30s, is seen in routine follow-up, already has diabetes. Medications include lisinopril and empagliflozin. UACR is 40. Calcium and phosphorus are comfortably within normal limits. PTH is stable at 150. So assay, we trust that PTH result. So which would you do next? All right. It's funny, we can't see the start cinecalcit tab. Okay, so it weaves and bobs depending on if somebody does that. All right, so we'll give it another 3 or 4 seconds. Am I allowed to put Tasso on the spot here?
I already answered. The correct answer.
All right. So Tasso's answer, you agree with the majority then here, I take it.
I didn't say that.
So I'm going to put you on the spot. What would you say?
No, you're good. Go ahead.
To be honest, I don't 100% know the right answer here, but I think based upon what I had learned, I probably would start calciferol in this case. It's not terribly advanced CKD, and I think you're going to have enough of an effect. PTH is high, not that high, but probably higher than our target for that particular stage, if we actually really know what we're doing, and those 27 guidelines are not terribly clear as to what to do in the situation. But I think that any of these answers are potentially possible. I probably wouldn't start calcium carbonate, and at this level, I personally wouldn't start cinecalcit. But I think there's a lot of uncertainty here as well, where the data are not great as to what benefit we're overall going to get from this. So to begin at the end, we're going to begin with a meta-analysis that summarizes a lot of the data that we have here. Don't worry so much about this, but really focusing over on this. In this particular meta-analysis, it came out about 2 years ago. They found 128 studies. And the key thing are what the comparisons are across these studies. So some of them compare nutritional D versus placebo. Some of them compare active D versus placebo. Some of them compare different types of vitamin D. A few compare active, so calcitriol versus nutritional, so like something like cholecalciferol, and all other different populations. So tons and tons of different comparisons here. Seems like a lot of work to do. So this is one of the slides, and I thought it was kind of interesting. This is nutritional D versus placebo, looking at an all-cause mortality outcome. And what you can see here, nothing doing. And Tasso showed this very well throughout his talk, is that we're not going to get a big mortality benefit. We shouldn't even think that we're necessarily going to get that for nutritional D versus placebo. What about activated D versus placebo in a CKD population? Again, for mortality, nothing really doing down here. Hazard ratio was 1.12, or the risk ratio, excuse me. Not too much doing for activated D versus placebo. One thing that we do know, if you look at activated D versus placebo, is we do get more hypercalcemia. I personally think the hypercalcemia risk that we talk about in CKD is a little bit overblown. Others may disagree with me, and that's just an opinion. That's not really supported by guidelines or anything like that. But you will get a trade-off here when you give vitamin D in terms of calcemia. And at least we've been taught to be paranoid about calcium levels in very advanced kidney disease. All right, so moving on to case question number 2. This is a 72-year-old woman, CKD stage 5D, so getting dialysis for 3 years. PTH is high. PTH is 550. It's been bouncing around, but reasonably comfortable at this level for at least the last 6 months. Calcium's 8.7, phosphorus is 5.4. She is taking calcitriol, getting at 0.5 micrograms every dialysis session, and is also on sevelamer as her binder, 800 with meals. We also have a vitamin D level measured by protocol at the dialysis unit. So which of the following would you do? We have 2 answers and you are evenly divided so far. There you go. 3 and we are evenly divided. All right. We need music for this. A little Jeopardy music, something else like that. All right. So there's a lot of disagreement here. We have plenty of time, actually, for this talk. So I think 38% said increased calcitriol, so doubling up in a disc ulcer. So what are we targeting for going up on calcitriol here? So what we really don't like, we don't like the secondary hyperparathyroidism here, right? Assuming, so something to lower the PTH. If the phosphorus were 7.2, would you still say calcitriol? No, okay. And if the calcium were 10.1? No, okay. But in this particular case, potential calcitriol. Cinecalcic got about 16%. And I'm assuming that's because, again, the calcium and the phosphorus are both reasonably well controlled. And cholecalciferol or ergocalciferol had about the same number. And I don't know, would you think there'd be any difference here between chole and ergocalciferol?
Yeah, the last time I wrote a prescription for ergocalciferol was a decade ago. So does that help you? No, there's absolutely zero reason to use ergocalciferol. So because you do that, the patient takes it, and then the level goes up, and you're like, okay, good job, and then the level goes down 6 months later. So you need daily, maybe weekly. That's okay. Exposure to vitamin D. So you just give them whatever. In this case, there's no data. So if you want to give D3, just pick your favorite dose and give it daily.
And I personally far prefer daily medications to weekly or biweekly or intervals. I just think it's a lot easier to be adherent and to remember something you're doing regularly. So I think the answer here in terms of my particular answer is I have no idea what the answer is here, to be perfectly honest. And I think any one of these 4 things are reasonable. The one thing I wouldn't do is no changes because the PTH, at least for me, is too high. And once it gets up at this point and you lose control, and it's going to keep going up. Any one of these other things I think are possible. My personal preferences, though, would be either the calcitriol or the cinecalcid, actually. And I'll show you why moving forward. If somebody said they want to really try these, more power to them, but I'd be prepared to jump in with an activated vitamin D or calcium mimetic. So what do the guidelines say? And that's what we're going to talk about here. And we've already gone through sort of interpretation of guidelines. This is how the KDIGO guidelines worked. And again, they were similarly rigorous. They did try to have specific questions they were trying to answer, and they follow this grade. So level 1 is a recommendation, level 2 is suggest. And you can see what suggest means. Suggest means that, there may be a lot of debate here, substantial involvement of stakeholders before it can be put into policy. Different choices could be appropriate for different people, so on and so forth. And you can see the level of evidence. High means that we have confidence that this is what we're saying is actually really close to the truth. Low and very low means, yeah, we're just kind of guessing anyway. There's a little bit of things to kind of point us in the right direction. And I will say pretty much the entire KDIGO mineral and bone disorder guideline at best is C or D and is pretty much all 2s, unless it's opinion. So as guidelines, these are kind of an outline, in some cases saying more of what we don't know rather than what we do truly know. So this is one of the key guidelines. In patients with CKD stage G3A to 5D, suggest that they can measure 25D levels and suggest that repeated testing could occur if you want to monitor what you're doing or see where they go. And that's a 2C. So this is pretty low, very little data to discuss it. And Tasso actually went in to even more data, remembering that this precedes the vitamin D guidelines he was talking about by several years. They also suggest that vitamin D deficiency and insufficiency, terms that we've decided are not favorable, be corrected using treatment strategies recommended for the general population. And so that's where this comes out. And I think you can sort of already see some of the contrast with what we just presented with guidelines that are a little bit more recent and cautious. But again, to remember, these are 2C. These are suggestions. These are not based on strong data. To show a couple of other guidelines, there's one that suggests that patients with levels of PTH progressively rising be evaluated for modifiable risk factors, including vitamin D deficiency. So that goes into the case that we just talked about, potentially suggesting that you could maybe manage this with cholecalciferol, for example, as sort of an extrapolation from that. Otherwise, why measure? And in adult patients with CKD, G3A to 5D, not on G3, to 5, not on dialysis, suggests that calcitriol and vitamin D analogs not be routinely used. So reserving these agents for dialysis only. So just out of curiosity, how many people here take care of people who are not receiving dialysis? Most. How many will use calcitriol on those people? Okay, I do sometimes too. So there you go. Also a 2C recommendation. It's a little bit bizarre though, because it also suggests that you reserve it for CKD stage 4 or 5 with severe and progressive hyperparathyroidism. So it says something and then it contradicts itself about a sentence later. Put that up there. And then sort of last but not least in terms of the guidelines that are out there. In patients with CKD 5D, so dialysis requiring PTH lowering therapy, it suggests you can basically do either calcitriol or an activated vitamin D, so the VDRAs, or a calcimimetic, or combinations of these based on the evidence. And this is actually a B statement saying that you will get parathyroid lowering from either of these. And that's what we know. And I don't think this field has appreciably changed since 2017. So just to summarize that, facts that we know. We know that activated vitamin D therapy lowers PTH. We know that activated vitamin D therapy raises serum calcium. And I think what we don't know is if changing this with vitamin D or with any other agent is associated with positive outcomes, particularly in our kidney failure population. We're not going to talk about the EVOLVE trial. That's the one trial that looked at cinacalcet. We can talk about that in questions. Different interpretations of that trial. It was overall negative. As I say, we're not going to talk about it, and then I talk about it, whatever. It was overall negative. There's some people who believe that was a function of contamination and crossover, and a lot of debate about that, and it probably won't be repeated, so we get a true answer. So what do we know from clinical trials? And there have been a handful that have looked at vitamin D in advanced chronic kidney disease. This is probably the largest by Ravi Tadani from when he was at Mass General, called the PRIMO study. And it came out in 2012 in JAMA. And this is what some of the guidelines, the KDIGO guidelines are based on. So if we're looking at our PICO markers, just like Tasso kind of went through in the last talk. This is a generally healthy population with CKD stage G3 to 4. So GFRs, on average, actually in the study, were around 30, 35 or so. The intervention is paracalcitol, so this is an activated vitamin D at 2 micrograms per day. If the calcium got too high, they would reduce the dose a bit versus placebo, and it was double blind, so pretty high quality design. Comparator again was placebo, and the outcomes, because it's only 48 weeks, it's less than a year, are things that you can measure. So they were specifically looking at LV mass index by cardiac MRI, and they also recorded adverse events like cardiovascular disease events. So this is the study, and what you can see here is it was not a huge study. There were 227 randomized, but not small either, at least for the field of kidney disease. Baseline GFR was 34. UACR was 170, so pretty high-risk population. Overall, kind of an average age for what we see in CKD studies, 65 years old, about half diabetes, and the baseline PTH was about 1.5 times the upper limit of normal. So what do we see? First thing that we see is that this lowers parathyroid hormone. And you can see that very effectively. Placebo's all the way up here with the PTH around 120. Both groups dropped a little bit at time 0, sort of a regression to the mean. Paracalcitol stayed way down lower, right around 60 as it went over the course of the trial. And so that's the one thing that we can prove for certain of this. But in terms of everything else, there was no difference in LV mass index, no difference in other MRI parameters. There were a very small number of events. You could maybe say there were fewer CV events with paracalcitol. It was 7 versus 1, but it's really too few to tell. This was driven a little bit by congestive heart failure events. Slightly greater EGFR decline with paracalcitol, slightly lower blood pressure with paracalcitol. The one other thing is there were a lot more hypercalcemia events, which they defined as greater than 11. So the take homes here, in CKD, like people, GFR is right around 30 on average, lowers PTH, raises calcium, not sure about anything else. One other study looked at a similar population. It's called the OPERA trial. This was done in Hong Kong. Came out maybe about a year after Primo. And very similar methods, so there was a much smaller study. It was only 60 participants in there. CKD stage G3 to 4, LVH by echo. A little bit sicker population that had higher LV mass index than in the Primo study. Paracalcitol here was 1 rather than 2. 1 year long double-blind RCT, similar outcomes. And again, you can see 30 in each arm. They had pretty good, actually they had great follow-up. Pretty much kept everybody in the study for a year. This is always a little hard to read when you have two different things in one figure, but just to keep it easy, the circles in this figure over here and over here are parathyroid hormone. This is the parathyroid hormone level on paracalcitol. So you see it drops down again, pretty similar to what we were seeing in the other study. This is the parathyroid hormone on placebo, stays up at a relatively high level. PTH is on this axis over here. So PTH levels rose to about 200 to 250 in the control group and dropped down into probably like a 75 to 80 level over the course of the study in the paracalcitol group. As expected, sort of similar changes in alk phos that mirrored what you would expect from higher bone turnovers you see in secondary hyperparathyroidism. And that's really about it. There was no difference in cardiac findings, slightly fewer cardiovascular disease events with paracalcitol, greater GFR decline with paracalcitol, which is, again, saw. So pretty similar events and much more hypercalcemia events. So almost exactly the same results, but very little that we can take home except that activated vitamin D reduces PTH, comes at a cost of higher calcium levels. All right, so I don't know what we do with that, but that's what we have in terms of information. What about if we compare nutritional D to activated D? Not much in the way of data. This was a study from Sabakovesdi and others in a VA population. And it looked at people with CKD stage 3 to 4 and had secondary hyperparathyroidism. It was non-blinded, compared ergocalciferol, so that sort of big bolus dose, versus paracalcitol. And their outcome, they were looking for PTH control, so 2 consecutive PTH levels with a 30% decrease from baseline. And what you see here is that paracalcitol is better, at least in this population, which had a mean GFR around 30, PTH of 170. Vitamin D levels were lower than we would want for population norms. The activated vitamin D gave better PTH control. So the response rate was 21 in the treatment group versus 7 patients in the ergocalciferol group. You can see again the PTH control here, if you're just looking at linear results, was also stable. So that's really what we know here. The other thing that you actually do know is the 25D levels actually went up more as expected with ergocalciferol than they did with paracalcitol. And that's the extent of our knowledge. I think that's kind of about it. One other study which I want to do, this is one that we did. Dana Miskellin at Tufts ran this one. This is in dialysis, actually. It's one of the few reasonably large studies in dialysis looking at nutritional D. In this one, we looked at maintenance hemodialysis patients who did not have severe hypercalcemia or hyperphosphatemia, used ergocalciferol. I was not involved in that choice. Tassa would have said something different. But that's what we did, versus placebo. And it was double blind. So people received a pill that looked just like the ergocalciferol. And we were, as investigators, we were blind. The outcome at this time was looking at change in erythropoietin dose, or EPO resistance. Obviously, if you're in dialysis, EPO resistance is a big deal. And just like has been told, there was a ton of observational data that suggested the better your vitamin D levels, the higher they were, the less EPO you required. So you can also see sort of a financial reason to look at this as a major question. So these are the results. It's a pretty typical dialysis patient, a little bit younger than average, but not much. Vitamin D levels were 16.4, which is low, lots of diabetes. Median vintage, it was a prevalent population, 3.5 years. A lot of people were on medications at baseline, and the median PTH was 427, so high, and not particularly inflamed. And so this is what we saw. The first thing that we saw, and these boxes are ergocalciferol, these boxes are the placebo, is that vitamin D levels went up if you give people nutritional D. Great, fantastic. So the vitamin D levels went up. And this is what we saw for PTH. At least in this particular population with secondary hyperparathyroidism, people were generally not changing the other meds too much, but there was some movement in other meds. There was no movement at all in PTH as a function of giving ergocalciferol. All right, so now what? Just to kind of reiterate and kind of return to some of the stuff Tasso showed us, this is some of the general population data on vitamin D and PTH. You can see there is an association. It's statistically significant, but it's an association. Just as an aside, these are in European units, so multiply that by 10. So 5 would be a 50-point difference in PTH for US units. Over here, this is what we see as observational data in people with CKD with a mean GFR of 34, where again, you see that vitamin D levels are associated with PTH. But we just saw that there's not a whole lot of difference in clinical trials. All right, so I'll do like 3 or 4 more slides and we'll have a couple more questions and we're gonna open this up to discussion. But I thought it was really interesting. As I was getting this ready, the Europeans actually released a guideline on this topic. This was titled The Role of Nutritional Vitamin D and CKD-MVD in Children and Adults with CKD on Dialysis and After Kidney Transplant, a European Consensus Statement. So this came out last month, I think in March, in NDT. And it's interesting. So I think we have a pretty full view of all the data here. And I'm going to be critical here because I don't think they went through anything in anywhere near the rigor that Tasso did when they were making the guidelines that he has already reviewed. So just to reiterate, this is a sort of a nice slide from here talking about the difference vitamin D and stuff that we've already gone through. One of the key things that they go into is that CKD is a state of dysregulated vitamin D metabolism and vitamin D hyporesponsiveness, and that you may have extrarenal production of 125 vitamin D. So talking about that local conversion that we talked about on the first slide, so not dependent entirely on circulating 25D, but that circulating 25D gets converted at specific tissues to 125 rather than entirely through the kidneys. They made 3 really key statements that I extracted from this. So first of all is that they want to monitor vitamin D status in these patients. It seems reasonable. Then they do something interesting. They actually recommend. And recommend is a loaded word in the world of guidelines. Recommend means that you have strong evidence to say this. Supplementing vitamin D to a level of 75, so greater than 30 in units that we use here in the US, regardless of CKD stage. So CKD G2 to 5D is like basically the entire population. To delay the onset or improve the control of secondary hyperparathyroidism, recognizing that it's uncertain over here. So I'll be critical again. You can't recommend and then say it's uncertain in the same sentence. You just can't do that, but they did that. And then they suggest replenishing vitamin D before using an active vitamin D compound or before concomitantly with an active vitamin D compound in very advanced CKD. So kind of what we talked about there. So going back to that first question, if you're going by the European guidelines, you would have given cholecalciferol, for example, before trying to tackle something with an activated vitamin D. I think there's other statements here, and they say specifically there's no evidence for benefit of vitamin D supplementation on cardiovascular all-cause mortality outcomes, and that there's no clinically relevant cardiovascular safety concerns with vitamin D supplementation. That last one's important because if we don't know what we're doing, I think we can at least be pretty confident it's not going to be terribly harmful, at least medically. It does cost money. Testing costs money. It's extra pill burden, and we have enough problems with that. But I don't think we're going to cause any medical harm. So the question comes, what do we really know? And I would just say, I mean, the one thing that we're really true on is if you give nutritional D, when it comes to nutritional D, you increase nutritional D levels. If you give activated D, you lower parathyroid hormone levels and you increase calcium levels. And this is the state of the knowledge we have right now. So with that being said, we'll go on to a case. So case 3 is a 65-year-old woman who has advanced CKD, not on dialysis, diabetes, has seen follow-up. She's on lisinopril, she's on semaglutide and empagliflozin. She's on all the best meds. GFR is 20. She has moderately elevated albuminuria at 240 milligrams per gram. Calcium's 8.9, phos is a little high. PTH is 190, rechecked from like 2 months ago, has been relatively stable in that amount. And vitamin D level's 32. Albumin's a little low, alk phos is fine. So which one would you do next? And I'm going to put you on the spot here on this one.
No. I don't do anything below GFR of 30. So.
All right, so I think we have a pretty good number here. So the majority actually would start a binder, probably low dose for the high phos. A little bit would start calcitriol. Some would make no changes. Some would give cholecalciferol, and nobody would give cinacalcet. And the answer based on the evidence, we have no idea. Just to put that, we have no idea what you do. None of this is well answered in any guideline we have, and there are not great data to support it. We'll assume that we've already done fantastic nutritional counseling and everything like that. I don't think that any of these are wrong. I would worry a bit with starting calcitriol here, but this PTH is also a little bit high. The calcitriol concern would be with the hyperphosphatemia. So I think maybe I would try to start a low dose of sevelamer carbonate, but based on absolutely no data and purely on my own opinion, and the follow-up with probably a little bit of calcitriol when I get that phos down a bit lower. But I'd obviously try diet first. So I think as we sort of sum this up, there's a lot that we don't know and a lot of questions that we still just don't have the answers to. Personally, in my practice, I don't typically in advanced CKD measure vitamin D levels. I focus in on the parathyroid hormone more because I think that's where I'm going to be going and I want to avoid getting control. Allison, who works with me, is yelling at me right now. But this is just style, and to try to argue that that's the right thing to do and what others is doing is wrong, we don't have the data to support it despite what the European guideline says. So with that, I wanted to leave plenty of time for questions and discussion here, and go Celtics.
Thank you. Yes. Thank you for that wonderful presentation. We definitely appreciate new data and really gain practical insights on how we approach vitamin D in a clinical practice session. So now we're going to some questions. Yes, the slides will be provided.
Yeah, mine weren't uploaded.
Okay. They will be, yeah. So we have some questions. For dialysis patients, is there any benefit to using nutritional vitamin D?
So I think that's the study, Dana Miskelin's study, I think suggested, again, using surrogate outcomes, that there's no benefit to doing that. It raises vitamin D levels, does not have an appreciable impact on parathyroid hormone, does not have an appreciable impact on ESA resistance. We looked at inflammatory markers. There was no difference in CRP. There were no difference in clinical outcomes. So I personally think it's not worth it. There's some interesting indications, like, for example, the oncologists are believers in vitamin D for colon cancer. I wouldn't cite the Miskelin data to say, no, don't use it in colon cancer. But we don't know the answer to things like that. So, but for normal routine situations, I would say there's no data to support using it.
So, by the way, this part is usually the most fun of this type of session. So this question is half good because the other half that is missing is, why. Okay, so you talked about CKD outcomes, but are there any other outcomes? So every question should be like, for dialysis patients, that defines the population. Is there any benefit to using nutritional vitamin D for right? So there is, as you mentioned, and it's well known, the 1-alpha hydroxylase exists outside of the kidney, and it exists for a reason. So if you ignore that, then you ignore the non-CKD potential outcomes. So if someone has CKD and they have prediabetes, well, the evidence is, yeah. So the beta cell does like 25-hydroxy-D and does not care about the kidney because it can make its own 125. So there are, just because there may not be evidence for CKD-related outcomes, there may be evidence for benefits outside of the kidney. Do we want to go to?
Hello. Yes. So I have a question about if the vitamin D correlates with decreased ESA use.
It does not.
It does not.
It does not.
Okay. All right. Thank you for
Hopefully I didn't
clarifying
misstate
that.
but no, there's no association.
Okay.
How high a level is too high? Someone has elderly people with serum vitamin D levels over 100. What are the real dangers?
Don't check the level. No, I mean, that's the answer. Don't check the level because I don't know what 100 means. I mean, there are people who just expose themselves to the sun all the time, and the level's 100 and nothing happens to them. So I don't know. So a level does not define toxicity, just like a low level does not define deficiency. So you need to look for signs of toxicities, and the obvious ones are hypercalcemia. That's it. So there's just yeah. So yeah.
Do you think that obese people don't benefit from vitamin D because it is stored in the fat instead of being used for its own metabolism?
Okay, maybe I'll start.
Yeah, this is not.
So excellent question. I mean, actually, they're all good questions. And may I say that whoever is brave enough to go to the microphone is prioritized over. So yeah, that's exactly right. So when we look at the subgroup analysis, whether it's diabetes or not, the people who are thinner or not obese, they seem to benefit more. And that is for two reasons. One is what you just mentioned in this question, that yeah, people who are thinner, they raise their levels, to a higher level than people who are obese, overweight for the same dose. So yeah, that is correct. So maybe we do need to give more vitamin D to people who are overweight, obese to achieve the same level. But we don't have the evidence that doing that. So if your goal is to raise the level, yeah, give more vitamin D. For certain individuals, like at risk for diabetes, the thinner individuals may have a different pathophysiologic mechanism. So maybe insulin deficiency is a problem, and they may get benefit because of that, not because of their being thin in general.
When should you get just a D level versus a fractionated D level?
Yeah, I mean, Tufts Medical Center, we have, you mean by D2 and D3, I think that's what it means. I mean, depending on the technology you use, you can get a fractionated level. Usually I ignore it because most of the time, we make D3, you buy D3 at the pharmacy, you prescribe D2, but, it doesn't really matter. So don't ask for fractionated.
What are the promising areas of vitamin D research in the areas of endocrinology and nephrology right now?
You can do the nephrology while I'm thinking about it.
As far as I know, there is nothing. To be perfectly honest, I don't think there's any studies going on in this particular field. The last big study that I'm aware of was the edulcalcitide studies, looking at IV calcium mimetic versus oral calcium mimetic. But there's very little activity here. There's some activity in the world of phosphate-lowering medications, but not much there either since the tenapanor studies. So I think what we have for knowledge right now in this population is what we have for knowledge. A little discouraging, but it is what it is.
I am more optimistic. We had a decade of excitement with vitamin D, 2010 to 2020 or so. And that was problematic because that's when also these large trials, the VITAL trials, were done. But these were not very good trials because it was a generally healthy population, and you gave a little bit of vitamin D, and you had 24 questions, right? So if you take a healthy population who's at low risk for fracture, and their vitamin D level to begin with is 32 nanograms per ml, and you give them vitamin D and the level goes to 36, nothing will happen. Okay, that's not a negative study. That's a bad study. So what evidence do we have? I think I showed you, maybe I convinced you, maybe not, that the evidence for prevention of diabetes or lowering the risk of diabetes in people with prediabetes is pretty strong. There are 3 aggregate meta-analysis, 1 IPD meta-analysis that has been shown this. The observational studies are super consistent. There was a trial just published last month. You may have seen it in JAMA. I don't know if it made it to the paper version yet, showing that vitamin D also improves multiple sclerosis-related outcomes. And the point I'm going to make again is that what is your population? What are you trying to improve? Is vitamin D good for you is not a good question.
And I think there are major questions in the transplant population. New transplant, especially where new onset diabetes after transplant is so common. And I think there may be some stuff going on there, but in the routine CKD dialysis population, there's not much.
How do you approach counseling patients about over-the-counter vitamin D supplements in light of current guidelines and evidence?
This is you again.
Again, who are you? And what are you trying to prevent or lower the risk or treat, right? So if you have pains and aches and someone was diagnosed you with osteomalacia, oh yeah, you need vitamin D to feel better, right? If you're just, feeling a little tired and you want to make yourself feel better, vitamin D may not make you feel better. Again, it depends what you're trying to treat. For the general population, the recommendation is follow the Institute of Medicine guidelines, which is 600 or 800, depending on your age. Of course, that's difficult to find or to remember. So I would recommend just, everyone should be taking maybe 1,000 units, especially in the winter months, and then live life according to good evolutionary principles in the summer.
So this question was in the chat, but also I just want to bring it to the microphone. Does using K2 with vitamin D show appreciable prevention of hypercalcemia since it works in calcium transport?
Yeah, I sort of saw that on the list there, and I have no idea the answer to that. I'm sorry. Vitamin K research is kind of an interesting place. There's been a little bit of it going on in advanced CKD and dialysis because it is thought to be a relatively low vitamin K population, and potentially through effects on something called matrix clot protein, that vitamin K supplementation may decrease vascular calcification. This has not been borne out yet, although trials are way too small, and people have been talking about and launching other trials because of the very high prevalence of vascular calcification and the harm it causes to kidney patients. But in terms of the synergy between those two, I couldn't answer that.
I agree.
So Tasso agrees that I can't answer that.
Would you test for vitamin D for low calcium levels after parathyroidectomy?
That's a good question.
Yes. Oh, absolutely. I mean, that's, I don't know, when we do parathyroidectomies, obviously the risk of hypocalcemia is very high. So, actually, hold on. No.
I think they're talking about, yeah. You're talking about after parathyroidectomy for tertiary hyperparathyroidism, I'm assuming, for kidney patients, right? Or just routine parathyroidectomy in the general population?
Tertiary is like, primary, 2 + 1. So yes, you will test, of course, if someone, you test for hypocalcemia, and then if someone has hypocalcemia, you're like, maybe the parathyroid has not, the remaining parathyroids have not recovered function. We need to give it some time. Oh, maybe they're vitamin D deficient, and then you check it and you're like, oh yeah, they're vitamin D deficient, meaning their vitamin D level is low, and that's why they're not converting to 125. So what you should be doing is actually measuring the 25-hydroxy-D in every patient before they go to have parathyroidectomy, and that has been shown to, if you check and replete, and that's a good reason to aim for something closer to 30, because then that's physiologic, right? You know that 30 is better than 20 for bone-related metabolism, and so you decrease the risk of hypocalcemia post-operatively if you optimize the vitamin D level before surgery.
Yeah. Now, in the tertiary hyperparathyroidisms, like the ones who are coming in with PTHs of 2,000, 3,000, so on and so forth, who get this vicious hungry bone afterwards, we don't 100% know what we're doing. I don't think that there's a reason to not assess vitamin D and test there, because to be honest, we know that we're sort of chasing them blind after surgery, and I think we probably want to optimize as much as we can. Clearly, in that situation, we also tend to give large amounts of calcitriol and large amounts of calcium as we handle this major physiologic challenge. So, I don't see why we shouldn't check this, and it could actually be helpful because those can sometimes be very dramatic and actually have long hospitalization courses as well.
What is your personal threshold or comfort level for PTH and ESKD on HD that prompts you to start or adjust your MBD regimen?
So this one's my question.
Fine.
So as everybody knows, the guidelines when they came out put forth the original guidelines, which were 2005, 2003, something like that, on MBD, had a statement that you should try to keep PTH between 150 and 300. It was recognized that that was overly prescriptive and probably not based on data. And when they reworded the guidelines, afterwards they said between 2 and 9 times the upper limit of normal. The guideline, I think, is okay. The interpretation of that guideline was universally terrible, because the way that was interpreted, so you can say roughly 9 times upper limit of normal, let's say 600 on many assays. So the way that that was interpreted was that many people on reading that guideline were like, oh, well, let's not start treating this until we hit a PTH of 600. And once you do something like that, I don't want to say the patient's lost. You've lost control over their hyperparathyroidism, and it is going to be super, super hard to get control over that. I will typically, and everybody's different here, I will typically start in a dialysis patient when patients get up into 200 or so. I'll start them on a low dose of calcitriol usually. Sometimes I'll use cinacalcet, depending on other factors, interchange these, and I really try to keep my PTH levels in the 200 to like 350 range, recognizing that the assays are terrible, there's a lot of movement, and I try not to overreact on these. But I really try hard not to let my PTH get out of control into the 400s or 500s and react very, very strongly if that starts to be the case. And I'll generally err on giving a little bit of calcitriol, like a 0.25 3 times a week to a hemo patient. And I'm good with that with the PTH anywhere between about like 130 and 200, just sort of keeping them on that level. That's me, it's opinion. But I found that I have very few patients who end up on large doses of cinacalcet, and I haven't had to refer anybody for a parathyroidectomy in a long time.
What are your thoughts on universal screening for vitamin D deficiencies in adults?
Whoever had this question was not paying attention. My thoughts are, do not do it. The opposite of the Nike commercial. No, you don't, because why do it? I mean, how many times do you do that? I mean, don't you have anything else to do? I'm actually serious about this. You know, you check it and it's like 18. You're like, oh, it's 18. Let me give you ergocalciferol. And then you do that, and then they come back, and now it's 26. And you're like, okay, that's great. And then you forget about it, and then you check it again, and it's, February, and it's 16. You're like, oh, it's low again. And then you give them ergocalciferol again. And so, there is what Dan mentioned, the cost, there's a financial cost, burden cost, but there's also the opportunity cost. I think you need to do something else for your patients. And vitamin, just because you can measure it and just because you can raise the level doesn't mean that your patient feels better. You feel better, but not your patient necessarily. So my thought is consistent with the Endocrine Society guideline. If you're healthy, more vitamin D will now make you more healthy.
I think the good comment there also is about pill burden. All of our patients have so many pills. Nobody likes taking medications. CKD patients, I'd much rather use that one extra pill I'm giving them for blood pressure or an SGLT2 or something like that. That's going to make, I think, a more meaningful difference.
I think that ties in with our next question. With relation to lower pill burden and ease of weekly dosage, is there still no suggestion of ergo versus chole?
Yeah, there's nothing wrong with giving ergo calciferol D2, once a week. That's fine. It's if someone is taking 12 pills and they don't want to take another pill daily, and it's easier for them to take the weekly one, that's fine. I don't have a problem with that. In general, the daily exposure tends to be thought as a better approach, but I'm not totally against the weekly. If that works for you and your patient.
A lot of questions.
I know, everybody is so interactive. That's amazing. If a patient with CKD comes to you on a high dose that's greater than 2,000 or 2,500 units daily of vitamin D3, would you recommend to discontinue it if they didn't have hypercalcemia?
If they don't have hypocalcemia? They don't have hypercalcemia. I usually, my answer may be different in non-dialysis and dialysis CKD. When people start dialysis, I just get rid of medicines. I get rid of anything that I don't think is going to have a major benefit. So I would generally stop the vitamin D, nutritional D. Again, this is pure style, and take it from there and see what their PTH is. And I'm going to be targeting PTH with my calcitriol and or calcimimetic. CKD stage 3, I think you treat like the general population. When you get into the 4-5s non-dialysis, 6 and 1/2 dozen the other.
Yeah, so this question says high dose over 2,000. Again, you're making an assumption that 2,000 is a high dose. Just like I don't talk about deficiency and sufficiency. It's kind of difficult to do. You shouldn't just say high or low. Just say the dose. Just say if someone is on 2,000, what should I do? 2,000 is not a high dose. Again, depending on what you're trying to achieve, I personally would not stop, but I also don't see patients on dialysis, so I'll leave that to you.
I'm sorry if I missed this. I had to step out for a minute, but would you comment on the ergocalciferol is a prescription, so it costs more anyway. But would you comment on the potential physiologic differences between, if there are any, between D3 and D2? D3 being the physiologic vitamin that we all have.
Yeah, I don't think there's good data that it's different. And both of them, if you do it in a similar equivalent dose, they achieve the same, levels. So there's no clear evidence, but there are some people who think that, D3, might be better than, just a little bit better than D2. And the reason we the use of D2 is a historical reason, that it was, the D3 was not available. And so D2 was easier to use in high doses. But nowadays you can find, your favorite dose, on Amazon.com. So there's really you can do 50,000 units of D3. So there's no reason to ever prescribe ergocalciferol. Again, I haven't done it in 10 years. So D3 is my choice.
We're good?
Do you ever follow FGF 23 levels?
No, I do not.
And
They may be interesting for research, though, still.
and the last one is vitamin D recommendations post-transplant.
Everybody like that picture of the Celtics? That's a whole other talk for another day that we didn't go into. I would, again, treat them more like what Tasso's saying, and there could be additional reasons, particularly with the high risk of diabetes, that you would want to continue to give vitamin D in that population. There's a whole other population of transplant patients who have pretty significant secondary hyperparathyroidism, where that's also really complicated management. And again, that's sort of beyond the scope here, because that can be very, very tricky. TJ?
Just one thing to think about, there are so many different vitamin D preparations on the market. I always tell my patients, look for the USP, because what we're giving them, we think, is vitamin D. But if they're out on Amazon buying some of these products that have no quality control at all, you really don't know what the patient's getting. So if they insist to go out and buy vitamin D for whatever reason, just tell them, look for the USP logo, because at least you have better assurance that they're getting a product that A, has what it says it has in it, and B, doesn't have bad stuff in it that some of the cheaper products may have.
Yeah, thank you so much for that comment. And when I mentioned Amazon, it was probably a bad comment. I don't have Amazon account. Don't buy anything from Amazon for the exact reason that you mentioned. So yeah, my recommendation is, if you go to, a pharmacy, Walgreens, CVS, hopefully they'll have, some good products, because their reputation is at stake, or you can get a brand name I just, mentioned the Amazon as a, the potential to buy anything, any dose you want. But yeah, thank you for that comment.
All right, with that, we end our session. Thank you so much. And